Hello and welcome to a basic guide to cardiovascular surgery presented by me, Joshua Maccagno. I am a South University Austin, PA student in the inaugural class of 2025, and this is a guide to set expectations and demonstrate skills to practice before the rotation for cardiovascular surgery. This video came into being because when I came on this rotation, I wanted to have a better understanding of skills that were needed prior to arrival, as this rotation only lasted 5 weeks. And in that time, the first week, I believe, was demonstrating basic skills that can be learned outside of the OR on your own time prior to rotation. That way, once you are in the OR, you can learn and utilize that time more efficiently, actually practicing on live tissue and patients. To begin, these are the skills that you should focus on, including sterility, suturing and closing technique, knot tying, self-gowning and gloving, and OR etiquette in general. This video is designed to be rewatchable and muted to watch skills in action. I encourage watching this video one time all the way through and then going back to sections that you find pertinent to your skills. In the center panel and on the right panel, you'll see proper technique on how to open a sterile gown and drop it into the field. And then in the left-hand panel, you'll see how to do the same thing with a pair of gloves. In the next section, I will show you specifically how to do each of these. When opening a gown and dropping it sterilely, just open the gown, make sure that the hands stay outside the plastic wrapping, and simply drop it onto the surgical tech's stand. Next, if you are to open your own gown and hand it to the surgical tech, first you'll remove the furthest away tab, putting it in the palm of your hand, repeating with the right side, then the left side, and finally the topmost tab, presenting it to the tech so that they can take it. Similarly, this is done with your gloves. Notice how I press it against my forearm and ensure that only the sterile part of the internal packaging faces the tech's stand. To ensure that we grab the spine of the gown, which is safe to do so, sliding our hands into the internal compartments and through the arm sleeves to ensure sterility. An additional note is to ensure that your hands stay inside the corduroy cuffs while somebody ties the back of your gown. Ensure that your hands stay away from your neck as well as above your waist, as this is the limitation of your sterile field. When I glove myself, I flip the gloves over, open up the packaging, and with my right hand I will pinch the crossed right glove with my 2 fingers, you'll see here, and then I use my left hand to flip the entire glove over my right hand. And I'll repeat this process with my left, and it'll take me some time to do this as I am not an expert at it. However, this is why this video was created, to help show and demonstrate different techniques and ways to practice to do this more efficiently. Now that you're gowned, you may often not have a surgical tech able to help you put your gloves on, so it is imperative that you know how to put your gloves on yourself for 2 reasons. 1, you do not want to be a burden to the team, and 2, you don't want to miss an important part of surgery because you're waiting around for somebody to glove you because you don't have the skill to do this yourself without breaking sterile field. I was absolutely in this boat on my first week, and I definitely missed out on a couple of cases early on the rotation due to not feeling comfortable putting on my own gloves and potentially breaking sterile field. My suggestion is to take a pair of gloves and gown home and practice this a few times on your own until you feel comfortable doing it in under a minute. Now we're going to watch PA Damien do essentially the same thing, except he is going to gown himself and do his gloves slightly differently than I do. He leaves them facing the initial orientation. He'll grab the gloves with his left hand, feed it to his right with a little bit more exposure out of his gown. I am not as comfortable as he is maintaining a sterile field, so he will then flip the entire glove over his right hand and pulling tension until it slides into proper position for himself, and then he will repeat this with his left hand. Something to note on my gowning and gloving on the right hand of the screen is you'll see that I keep the cuffs inside my gown to maintain the sterile field, ensuring that my hands do not break the sterile field. This is something I do to help me feel more comfortable gowning and gloving on my own. Now that you're gowned and gloved, you'll need to hand the card to somebody holding the white part. They may touch the blue part. You will spin to your left, pulling with your left hand the string out of the card and tying yourself. The person who you hand the card to may be sterile or not. In cardiovascular surgery, when we are holding the needle drivers, we use a palm technique. So a finger may go into the bottom part of the needle driver, which would be your ring finger. However, we never put our thumb into the top part of the needle driver. When we load our needles, this is a 90-degree, and in cardiovascular surgery, we generally load to a 45-degree angle. This helps us suture into the deeper planes more easily. The best piece of advice I have for practicing these techniques is to walk around with a needle drive and just practice palming the needle driver. First things first, we need to make sure that with our hand ties, our suture or silks are even, and then we're going to start to tie with our left hand. First, we're going to make this little A-frame with our hand, and we're going to cross over the center line. We're going to flick our finger down behind both of our sutures and then up and through the center of the knot. We're going to push down with our middle finger. Normally this would lead us into the next tie, however it's best to throw two of the same ties in a row. So we're going to do another A, flick through up and around, pushing down with our middle finger. This will help key us off that we're on our next knot, which is going to be the karate chop. You're going to turn your palm to the sky. You're going to have one string crossing, again putting our middle finger to the palm, pushing out, grabbing the suture between our ring finger and middle finger, and then pushing down with our pointer finger. Now the pointer finger is going to cup underneath our suture. We're going to make this A again. Sometimes you get a little stuck. Pull a finger down, up through the center, and again we're going to push down with the middle finger. Now we're going to come back to a karate chop. Middle finger pulls, then pushes, and then we turn the hand back over and push down. Now we're with the pointer finger. We're going to make our A-frame, touch the centers, pull towards us, flick out, and then you're going to want to repeat this until it feels comfortable. I fumble a little bit here, but that's okay. So you'll want to get this down to where you can do it fairly quickly, because in the OR things tend to move pretty fast. One major thing to note in addition is notice that my right hand keeps the string pretty much parallel and with a decent amount of tension on it. This is your post hand and is very important to keep vertical throughout the tying process. When practicing at home, if you have limited supplies, one thing you can do is your post hand can switch to your tying hand, and then you just have some extra suture length to work with. The main reason we tie with our left hand specifically is so that we don't necessarily have to put down the needle drivers. We tie the same way as we do with silk ties as we do if we have a needle in the right hand. So imagine throughout this process that a needle driver is in my right hand, I'm still able to tie a knot and keep the needle in my needle driver. As I finish up throwing a few more knots here, you'll notice that I'm going to come in with some scissors and show you how to properly cut once your knot is sufficiently tied. You're going to pull tension and present the knot. Either you or someone else will cut it. You're going to put the scissors as close to the knot as possible, line it up, tilt them to the side, that way you know where you're at, and then cut with intention. For suturing, this video is sped up just to have demonstrations, so I encourage you to go back and watch this video in a slower time, and I'm just going to talk through it right now. So one of the main things we need to do when we're closing the sternum, a lot of times as a student, the lead surgeon will likely do this initial stitch due to help reduce the complication rate of post-surgical stomach herniation, which is generally only repairable with another surgery. This is just me practicing it so that I can potentially do it at some point. The first thing we do is we take the bite, and then when we come back, we are going to feed the needle back through the apex of the wound. This will help bury the knot and as you can see just a moment ago, I am ensuring that the needle is facing into the needle driver. That way I do not accidentally poke somebody else, or if there is somebody in the field that is moving things around, they don't end up poking themselves. When suturing the fascia together, it's important to come 90 degrees straight down. You'll hit the sternum, and that you know that you've hit the correct depth. You will then rotate your wrist and take the needle out of the fascia, ensuring to grab a significant bite. You will pull the needle through, come out, and then you will do the same thing on the opposite side. You'll go 90 degrees down into the sternum, taking a large piece of tissue. What you see right here is I am tightening the sutures. You can put the needle driver in through the underside of the sutures and pull up in order to tighten and get a little bit closer of an approximation to the wound. The reason we need to get fascia layer approximated as well as possible is due to something called mediastinitis. Mediastinitis is a significant post-operative infection of the mediastinum that has a significant post-operative mortality rate if a patient gets it, so ensuring that the fascial layer is closed appropriately is very important. You'll see a time skip here. Generally there will be, the PA will be closing on the opposite side of you, in this case on my left, so they will be running a suture at the same time you are, and you'll meet in the middle, and then you'll hand tie them together and then move to the next layer. And again, we're going to be here starting the first layer. Again, sometimes the PA or the doctor will do this layer first, again, just to prevent any kind of complications that we already discussed. But as you get more comfortable and it's not the fascial layer, they will allow you to do the subcutaneous layer. And again, we are driving the needle through the top portion, and as you can see here, I had a problem with my suture. I accidentally fed it through itself, and you want to make sure that when mistakes like this happen, you don't just keep going. You need to fix them, because we, at the end of the day, want what's best for the patient, and make sure you're accountable for yourself to do this. Part of the reason I left all of this mostly unedited and just sped up was to show you that you're going to make mistakes, and I'm going to make a few more throughout here, but hopefully you can slow down the video, see what I did wrong, and hopefully adjust accordingly. Now on the subcutaneous layer, our target for the suturing here is going to be just superior to the subcutaneous layer, and we are going to be doing more of a horizontal suture rather than a vertical like we were with the fascia layer. And again, we're going to meet in the middle, where we will hand tie the two sutures that are running towards each other in the center together. Now, the main reason you'll see here as to why we learned how to tie with our left hand is so that we can keep the needle and suture in our right hand, tie with our left hand, and then if we potentially needed to continue suturing, we would be able to do so. Now what you'll see is something called hiding the knot, and also could be burying the knot. We're going to go into the skin and then come out the side anywhere. It doesn't really matter. And then we're going to cut the suture flush to the skin. This helps hide the knot deep to the wound so that it is less likely to dehiss or cause irritation. While finally doing the last layer of skin, the deep dermis subcuticular suture, the Adsons I had unfortunately were not the best set and could not pick up the needle without putting it in between the teeth, as you'll see here in just a second. So I don't necessarily recommend putting the needle into the teeth of your Adsons. It could dull the needle, you could accidentally clip the suture off, but this was what I had while recording, so I had to make do with what I had. One of the other things you just kind of have to make work is the Adsons or needle drivers you have, and practicing with different sets, as sometimes you'll get a better set than another day, and it's your job to kind of be adaptable and work with what you have. Our target here for the deep dermis suturing is completely horizontal to the closure of the wound. You'll see that I am everting the wound pretty heavily, making sure that I'm coming in now horizontal to the skin, making sure that I'm getting the layer that's between the deep dermis and subcutaneous layer, and I'm trying to make sure that this is as even as possible to make sure that there isn't any skin tenting or dog ears, which is a misalignment of the skin at this point. Regardless of which layer of tissue you're suturing, you want to try and ensure that your bites are evenly distributed and that your sutures are all approximately at the same tension, again to avoid any dog ears or tenting of the skin. At this point, I am going to cut off my suture as I have imaginarily run into my PA or whoever is suturing the closure with me, and we're going to skip ahead here and look at the hand tie. One thing to note about the final tying layer, if you hand tie, make sure to, with your left hand when you're tying, pull the suture parallel to the wound closure. It'll help get a tighter approximation and hopefully avoid any irritation. We're going to then bury the knot again. I like to go the opposite direction of whichever way I did the last knot burying. That way I don't run into the suture and end up causing any kind of issues. Thank you for your time, and I hope that this basic guide to cardiovascular surgery was a good primer for you and that you get some valuable knowledge out of this.